We are talking kind of from my office. I had clinic this morning and I'll see some more patients this afternoon. So when I was thinking about this talk, and I was thinking, I know this is virtual, but I still like a more intimate setting. I like when I'm able to sit and talk with people. And I thought, what would be the best use of your time and what do I get asked the most when I'm outside of this office and I don't have this white coat on? Often people will, when they find out I'm an oncologist, they'll just ask me questions. And so I really wanted this to be as interactive as possible. And I was thinking that with this talk, I wanted you all to kind of get inside the mind of an oncologist. What do we think about when we see someone with newly diagnosed metastatic breast cancer? And so during this talk, feel free to, type questions. We'll get to them. I have some slides for you, but I want this to be less teacher student and more kind of, let's just talk amongst friends. Okay, so I will go ahead and get started and we'll go to the next slide. So when I see someone who is newly diagnosed, the way that I first approach the diagnosis, the first thing that I look for are the biopsy results. What I'm looking for on that biopsy, one, I want to confirm the diagnosis. I want to confirm pathology. And what I'm looking for on that pathology report are something called biomarkers. And biomarkers are basically three tests that every oncologist looks for in breast cancer, and it's the estrogen receptor, the progesterone receptor, and HER2. The reason why the biopsy is so important is because that's how we frame all of our treatments. Now, I know there are different types of people with metastatic breast cancer. There may be some of you who have been diagnosed and treated with an earlier stage breast cancer, and it may have returned. Or there may be some of you, although it doesn't happen as much, about 10% of the time, you may have what we call de novo metastatic breast cancer. And so that means that you weren't initially diagnosed and treated, but at the time of diagnosis, the cancer has gone beyond the breast. And so I really like when I'm looking at the pathology report. First, I confirm the diagnosis. I look at the biomarkers. Is it estrogen positive, progesterone positive, or HER2 positive or negative? And then I want to know a little bit about the history. Is this breast cancer that's been treated before, or is this breast cancer that hasn't been treated before? And then one of the things that we'll do are scans. Typically, we'll do a CT scan or a bone scan or a PET scan to evaluate the extent of disease and also the sites of disease. And during that initial visit, we also will perform labs. And with labs, I'm looking for first basic blood work. There's a test that everyone will get, and it's called a CBC, a complete blood count. I want to know how your white count is doing, whether or not you're anemic. How are your platelets before we get started with treatment? I want to do a test called a CMP, which is a comprehensive metabolic panel. And I'm looking at your kidney function, your liver function. What are your calcium levels? Um, Other labs that I will get if they have not been done before is genetic testing. Have you been tested for hereditary cancer syndromes like BRCA1 or 2? There's something else called PALB2. We like to check for that because that may change. We think about treatment based on that. And then there's another type of testing that we do, and that is either testing of the blood and or the tumor itself. And when we test for blood or the tumor itself, what I'm looking for are certain characteristics of the tumor itself that may make you a candidate for different types of medications that otherwise may not be approved in a breast cancer space. And so we call that testing now next generation sequencing. And so, Stephanie, I'll bring you back in. Just,
Sure.
just to, I'll stop and pause there before I go forward, just to see if maybe if there are any questions, anything that you think that our audience really needs to know.
Yeah, thanks so much, Dr. Lamar, for the information you've already provided. We did have a question about how breast cancer spreads. So if somebody had an earlier stage breast cancer, kind of what's happening in the body that then results in it becoming a metastatic breast cancer diagnosis?
Oh, that's a really good question. So, you know, usually when I'm talking to people in my clinic room, and we're talking about kind of the evolution of breast cancer treatment. So if we go back, goodness, several decades ago, when women were treated, women who had breast cancer would get kind of these disfiguring mastectomies, where we would take the surgeon would take as much breast and skeletal muscle and rib, and it was that used to be a standard of care for treatment of breast cancer, to do these big surgeries. And what we found over time is that it really didn't matter how big the surgery was. Sometimes there are these small microscopic cells that you really can't see. And so, in the earlier stage setting of breast cancer, often, depending on the type of surgery you have, but sometimes we'll do a mastectomy, or we may do a partial mastectomy, where we take kind of the tumor and in the area around it, we may check the lymph node. And then you have radiation, and depending on the subtype of the tumor, we may give you, more medication like an anti-estrogen pill. The goal of that is to target something that we call micrometastatic disease. And so the question really was, how does breast cancer spread? But what can happen is that you have these microscopic cells that the surgeon can't see, that maybe wasn't cleared by radiation, or that it was able to overcome an anti-estrogen pill if you were, estrogen receptor positive. And that's the cell that will either want to come back, sometimes in the same breast, depending on what was done. There is a risk for it coming back in the other breast, and sometimes it will go, throughout the body. And sometimes the patterns of spread can be different based on the subtype of the tumor. And so, one of the areas that we often will look for, the bones. Sometimes there can be a propensity to go to the bones. We also look the liver and the lungs, depending on the type of breast cancer. So you can never really predict in where the breast cancer will go. And what we try to do as much as we can in the earlier stage setting is to try to prognosticate, to see who will be at a higher risk for treatment, for the cancer to come back.
I see. Thank you so much for that really thorough answer. That was also, I could follow it well. Thanks for explaining it so clearly. Hopefully, I'm sure our audience feel the same way. We had a question that came in while you were speaking, so I'm just going to read that directly from the screen. It says, how does BRCA or PALB2 change treatment once someone is already diagnosed metastatic? And the person who submitted this question is somebody with a de novo diagnosis with PALB2.
Well, so the thing about with BRCA, I'll start with kind of the BRCA part of it. There are medications that are approved in the setting. They're called PARP inhibitors, and so that's something that we think about. With something like PALB2, sometimes we kind of think about that as a BRCA3, and so because the risk is so high. And so I have patients with PALB2, and one important thing is to make sure that family members know. Um, Really, we like to know all the potential risk factors because, as we're looking through scans, sometimes it's a matter of, are we sure that this is a breast cancer? And that we're targeting our treatments the way that we should. So really, we just try to have all the information we can at the onset, so that we're not surprised. But also, there also are clinical trials, and actually, in one of the slides that I had, it was just talking about clinical trials and the importance of clinical trials. So with every piece of information that we have, there may be a trial or something specifically for that. So we just try to get all the information up front. That was a really good
Yeah,
question.
it was. And thank you for your answer as well. And then we have another one from a member of the audience. Does it mean anything where the cancer goes first?
Ooh, these are some
They
fantastic
are. Yeah.
questions. These are some really
Yeah.
good questions. So yes, it does. And when I was talking about inside the mind of an oncologist, and I'm looking at the pathology report, okay, so I know how I want to tailor treatment based on that pathology report. And then we look at the scans. And it's really important to know where the sites of metastasis are, because we may think about it differently. If I think there may be a talk later on about the bones, but if there is cancer that's in the bones, we really want to try to avoid as much as possible a fracture in those bones. And so we will give medicines to try to strengthen the bones. And also, it may mean that sometimes I may send you to a surgeon or to a radiation doctor if there is a risk of a bone breaking. So that's a site where I think about it differently than I would a place like the liver, for example. Um, and so when I also think about treatment, now we put often we put treatment in three different boxes as an oncologist. Those boxes are starting to get muddied, but for the purposes of this talk, I'll kind of stick with those three boxes. And box number one is the estrogen positive box. Okay, so in the estrogen positive box, we want to know about the anti-estrogen therapy that maybe someone has been on before. But if they're de novo, then they haven't had any anti-estrogen therapy before. Okay, because we do know that one of the side effects of anti-estrogen therapy is that it can cause thinning of the bones. And so making sure that the bones are strengthened is really, really important. The other thing that's important in that estrogen positive box is if we are metastatic, usually we will use a combination of pills or a combination of pills and a shot. And so that is what I do the overwhelming majority of the time. However, if there is something that's called a visceral crisis, and that's kind of oncology speak for I'm very, very concerned about um, that there's the cancer burden is so high in the body and I may need to quickly get it down, then I may think about something like chemotherapy. Okay, so that's kind of how I think about it differently. But the overwhelming majority of the time, we're able to control the disease, even if it's in the liver, even if it's in the bones, even if it's in other places, with kind of that combination of pills or pills in a shot. So that's kind of that estrogen positive box. In the HER2 positive box, we always use anti-HER2 treatments or monoclonal antibodies that are directed against HER2 as a part of the combination of treatment. Now, recently there's a new entity called HER2 low, and that's why I said that the waters are a little bit muddy. So what HER2 low means is that when the pathologist has looked at, on the microscope And we look for something called HER2 expression. That's how we know if you're HER2 positive or negative. And so if someone is HER2 low, they may be a candidate for a HER2 positive drug, even though they technically weren't HER2 positive. So that's something that's happened very recently. So if you're estrogen positive, you probably want to ask your oncologist, hey, have you looked at my HER2? Am I HER2 low? Because we used to always say HER2 negative. And now there's a spectrum
Uh-huh.
of HER2 that may impact treatment. Then the third box is what we call triple negative. And so that means that there is no estrogen uptake, there is no progesterone uptake, and there is no HER2 uptake. And so in that setting, I we think about chemotherapy, we think about immunotherapy, sometimes depending if on the markers on the information that we get back. But also there are clinical trials available, and actually we have trials open right now that are comparing some newer drugs against the standard chemotherapy that we give. So there's a lot happening in the triple negative space as well. So um, I talk so much I don't remember the original question, but hopefully I answered how we. Oh yeah, it was how I think about treatment based on the sites of disease, I believe was the question. But I think I expanded it a little bit to how I think about treatment based on the sites and the subtype of
That's
disease.
great. Thank you so much. That was so informative, and obviously people can get some takeaways too from what you're saying and what they can bring back to their own care team. So that's really important. Um, so we do have some other questions, but we'll have more time. So I'm going to suggest perhaps if you want to move forward, and I have all the questions, and we'll still get to as many as we can as you go forward.
Sure. So I think with my second slide, I mean, the audience is on top of it. And, we've kind of gone through some of what I was thinking about. We'll go to the next slide. And so that was about treatment and talking about treatment based on subtype. So really, just like I said, knowing your biomarkers, that estrogen, the progesterone, and the HER2 is important, but also the treatment based on location. I think I kind of went through that about whether or not it's in the bones, where how we think about treatment, and this is just another plug for clinical trials. And so one of the things about clinical trials that I'll be honest, I didn't understand until I was training to become an oncologist. I really didn't understand how important clinical trials were. And so, really, the majority of the things that we do in oncology is because of the clinical trials that happened before. So, what is standard care now happened because we did a trial that compared what we used to do to what we do now. And even when I was talking about how decades ago, a long, long time ago, women would have these mastectomies that were just so disfiguring and just really hard to recover from. The reason why we don't do those anymore is because of the trials that showed us that, hey, we can treat this and and have better outcomes. So really, you want to talk to your oncologist to see if there are clinical trials available. And you want to do that at every step of the way. So you want to do it before you get started with your what we call first line treatment. And I guess I should talk about that too. As an oncologist, we always talk about lines of therapy. And what we mean by that is first line therapy. That's the very first treatment plan that you received. If for some reason that first line therapy doesn't work or you don't tolerate it, then we move on to second line therapy. And so sometimes when the FDA approves different drugs, they may approve those drugs depending on the line of therapy that it was studied. So that's just what we mean if you hear us say first line, second line, third line. All right. And we'll go to the next slide. Now, the care team is so important. So, we've kind of gone through the pathology of the diagnosis and how we think about that and how we think about some of the treatment. But really, with oncology, we practice as a team. So there are nurses and nurse practitioners and physician's assistants and pharmacists and nurse navigators and financial coordinators that are all a part of your oncology team. So often you may see, a white coat like me kind of at the top of the team, but I function because there are all these people who are so invested in your care. And so, really, I'm sure a lot of you on the call are know your team well, but you really want to get to know all members of the team and know how your particular clinic operates because every clinic is different. And what the generally you will be with the medical oncology team. The medical oncologists, we are the oncology doctors that give chemotherapy and medications. We sometimes will call this systemic therapy. It's treatment that goes all throughout the entire body. But we work with radiation doctors. So radiation doctors will will target an area that may be causing pain or discomfort or something that we need to control. The radiation oncology team will target that. And of course, the surgeons will do the surgery part of it. But also, I think nutrition is an important component because we want to make sure that you're eating. And sometimes with treatment, you can have taste changes or a poor appetite, or you may have GI symptoms that may impact your treatment. So having a good nutritionist or a dietitian, it's good to have at least a discussion once or twice throughout treatment. I have some patients that talk to the nutritionist all the time, but I think all of that is important, important components of the team. And I mentioned clinical trials. If you are on a clinical trial, then you have a research team that with a research nurse who will be a part. And honestly, the last part of the team that I have on the slide is actually the financial team. And so we know that the cost of care, especially in the US, can be exorbitant. And so I want you to meet your financial team. You want to meet with them early and you want to meet with them often because it's really difficult to be going through this diagnosis, but to be also kind of fighting with the insurance companies and fighting with um, the money part of it. So, kind of meeting with the financial team and knowing what expectations are. And then also that helps us to know because we often will apply for grants or we may reach out to the drug company to see if we can get medications at a discounted price or for free. So reaching out to that financial team early will let you know if some of these things may be available to you. Okay, Stephanie, anything that
Yes, because we have this fabulous,
I'll just take a pause for
yeah,
questions.
sorry, fabulous audience. So questions, very thoughtful questions are coming in. I wanted to just mention before we move to those that thank you for outlining and explaining the various members of the care team and that you brought up the financial piece because I think that's huge, as you know, and we often hear that from the LBBC community. So thanks for talking about that.
Yeah, no, it's a big deal, and we fill out financial forms all the time, and so we really want to. Everyone is invested in your care, so certainly, whatever we need to do to try to help is what we would want to do.
Great, thank you. So there's some really interesting questions. I think I'm going to start with this one. How do you help patients navigate treatment options and evaluate them to help them make a decision?
Ooh, I like
I know,
this
it's a good one.
question. Okay, it's a really good question. So, usually what I'll do, and sometimes I don't do this 100% of the time, but I actually like to write, especially with a new visit, on my examination table. So the little paper that you sit
Mhm.
on, I like to use that as a chalkboard and kind of write out the treatment options. And then I'll also write out pros and cons of kind of the treatment options that we recommend. I'll give you an example. In the estrogen positive space, I said that we have pills. There are three different pills that we can use. How do we decide between the three, right? Some of it is based on the side effect profile of the drug with your past medical history, right? So, for example, if maybe you have um, GI issues normally, or if you have cardiac issues normally, that may point me in a different direction. And I would say that to you, like, hey, we have these three drugs. Let me tell you why I'm thinking about this drug for you. Sometimes it's a matter of honestly cost, right? If this drug is substantially cheaper and the difference is not much at all, if any, then I may say, you know what, if I were you, this is what I would think about. Um, in other spaces, sometimes in the HER2 space, the first line treatment is often pretty set if you're not on a clinical trial. But then once we start going into the second line and the third line, there are all kinds of options. And so you're thinking about it differently. In the triple negative space, there are different options as well. And so sometimes the treatment I may use, for example, in triple negative, if you have something called neuropathy, which is numbness and tingling of the hands and feet, and I know a particular chemo may make that neuropathy worse, I'm going to say, you know what? I'm not thinking about that drug for you because, this may be a side effect that could get worse. And so that's really what we think about. And that's why it's really important when you're talking to your oncology team, making sure they know everything about your past medical history. Believe it or not, sometimes simple things can get missed. There is a medication that can cause the blood sugar to be high. If we just happen to forget that you have diabetes, that could be a big deal. And it's easy sometimes to forget these things when you're dealing with the stress of the biopsy and the scans and going back and forth to appointments, that sometimes these little things can get missed. So making sure your oncology team knows all of these little details, that's really how we think about treatment.
Great, thank you. That was really interesting to hear your process and the writing on the paper, and I loved hearing about your
Yeah,
approach with people. There was a question a moment ago, or a little bit longer ago, related to clinical trials. I just want to find it because it feels
sure.
somewhat tied to a couple things you've just said. Um,
Mhm.
how early do you consider trial treatment? Is it mostly after you have exhausted all other treatments?
Ooh, good question. Man, these are some great
There.
questions. So I think you think about clinical trials early and often. And actually, let's talk about trials. So in a former life, I used to do clinical trials and write them and everything. So when we think about clinical trials, there are different phases of a clinical trial. And so generally, generally there are three phases, even though there are more. If someone's a PhD, I'm only going to talk about the three phases of the clinical trial because these are the ones that matter the most to the audience, okay? So a phase one clinical trial is a trial that will give you, the purpose of that trial is to get the dose of the medication that works best. What's the dose of the medication that's best tolerated? So really with the phase one clinical trial, we don't know yet how the drug works. What we want to make sure, what dose is safe and effective for us to give this to a larger group of people. That's a phase one clinical trial. We're dosing phase one. With the phase two clinical trial, we're trying to see, hey, how does this drug work? Does it lead to responses? How many responses? How quickly was that response? That's a phase 2 trial. With a phase 3 trial, we are comparing the standard with what we do right now to that drug that we know works, but is it better? And so that's a phase 3 clinical trial. So really, I mean, I like to think about clinical trials early and at each step of the process. So actually, my research nurse, sometimes she's like, we've already screened that patient. Like we screened that patient a month ago. I was like, oh, well, screen them again just in case, something else has come up. So it really is because of clinical trials that we are where we are in oncology. Now, I will tell you just practically, okay? So with clinical trials, some of the clinical trials, what I've noticed with trends in clinical trials is that sometimes they can be more involved, right? And so sometimes there may be an extra test or an extra something that may be a part of the clinical trial that may be a little bit more than what we do normally. Okay? There are some trials that may say, hey, you know what? I want another biopsy. And so, or I want to do these particular labs so many hours apart initially. So it's very possible that, it may be more involved initially. So don't be surprised by that. Don't let that scare you away. Um, but if you have a clinical trial, one of the things about clinical trials too is that it's your choice. We can't force you into a clinical trial to say, do this trial. No. I like to tell patients who go on trials, look, we're going to be friends whether you go on trial or not. Okay, but I want to present this to you as an option for you to consider. And, you really shouldn't feel forced. You want to make sure that you understand, the trial, that it makes sense to you. And always realize that even if you go on a clinical trial, doesn't mean that you're trapped there forever. Okay, if you don't like it, if you don't want to do it, you're free to stop. Okay, so it really is, the clinical trials can benefit you potentially, but they certainly help others down the road. And right now, we are benefiting from all the people who participated in trials, years ago.
Yeah.
That was a great question.
It was a great question, and thanks for kind of drawing in the history piece of that, because I think that's a really interesting way to think about it, as well as how important it is for people to feel well informed and understand their options, and to have somebody
Right.
like you on their team and others that they can discuss that with.
Right, and not to feel pressure. So the goal of it, you don't want to feel pressured. You just want to know about it because really in breast cancer, there have been so many changes in the last 2 or 3 years that, sometimes you really have to like, oh man, this is moving at a rapid pace. And that's great. It really is.
Yeah, it is. It's really encouraging. That is so helpful. Thank you. So I would suggest there are some more questions. Maybe we could pause on them and go back with.
I'm okay to keep.
You go to take the question. Sure, then
if,
let's keep with questions.
I'm good. I'm good to keep taking
Great.
questions, and then if I'm open, I'm free. My door's
okay,
locked.
That's great. Well, thanks for being so flexible. So there is a question from somebody. At what point during the newly diagnosed discussions do you bring up palliative care?
Ooh, that's a good question. Yeah. So let's talk about palliative care. So palliative care is palliation of symptoms, and often we say hospice palliative care, but they're really different entities. So palliative care, we're palliating symptoms. I often bring up palliative care when there are symptoms that I can't control. So I'm still very interested in who, we're still very interested in continuing treatment, but sometimes it's pain. You know what? I haven't been doing a good job of managing pain, right? And so then I'm like, you know what? We have to get palliative care on board because I need someone to better manage your pain to make sure you're getting what you need and how you need it. Sometimes it may be nausea. Sometimes it may be, whatever kind of symptom that we have, I will incorporate palliative care. And so I also think a discussion of palliative care is important early on so that you know that, like, hey, you know what? For whatever reason, this is not being controlled. I may need to have palliative care on board, so that you're not concerned or afraid about it. I think the earlier, the better. Now, let's talk about hospice. Hospice is when, we've had the discussion that maybe continuing treatment is not what we want to do, you know? And sometimes that may be me saying, you know, what I say in clinic is that, look, I always have a chemo I can give. I can always give chemo. Chemo is always there. But just because it's there doesn't mean it's the right thing to do. And so sometimes we get to the point where I don't think that my options are efficacious enough. And 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 we may say, you know what, we should stop treatment. And that's when I think about hospice. I've had some patients who said, you know what, Lamar, I've heard what you have to say. I don't want any parts of it. And that's okay. That's okay as long as you're making that decision. This really is a discussion between us because at the end of the day, I say this all the time. I am a consultant. You are the CEO of your body. My job is to advise, inform, but at the end of the day, this is your body. So I've had some patients where, I think I have great options, and I'm like, we can do this and we can do this and this is going to be great and we're going to do this. And they say, that's not what I want to do. And that's something that I respect. And so I say, okay, I understand that. So let's see how we can make this best for you. So, remember, I never want any of my patients to feel like they're doing something for me or to feel like they don't have a voice in the process.
Yeah, great. I love the kind of image or concept of you as a consultant and them as the CEO of what's happening.
Yeah,
It makes a lot of sense. Yeah, thank
yeah,
you.
yeah. And I will tell you, just given like healthcare. So let's just talk about the logistics of healthcare because everyone is busy, everyone is, it seems short on time. So a way to maximize your time with the oncologist or with any physician for that matter is if you can write down your questions. I can't tell you how that helps. If you write down your questions, kind of maybe not 30 questions, but kind of your top 3 to 5 questions that you have and bring them every visit. And so I had one patient who would bring a note card. And so every time I saw her, there was a new note card. And it got to the point that I would walk in and just reach for the note card. And as I'm talking to her, I'm looking at the note card and answering questions. And she actually bought me a box of note cards. I thought that was but it's really that's a good way to maximize your time to make sure that all of your needs are being addressed. Because sometimes we can easily get distracted and maybe something that was important doesn't get addressed, and that's not what we want.
Absolutely. Thank you. So just given all of the many things that people living with metastatic breast cancer have to juggle in the way of treatment decisions and managing the course of treatment, and everything else happening just in their lives outside of that or along with that. I was wondering if you could talk a little bit about just the emotional impact of metastatic breast cancer at time of diagnosis, and just how you might recommend people to kind of think about and manage that element of their care.
Yeah. So um, there's nothing that prepares you for a cancer diagnosis. Anytime, cancer is attached to your name, you are fundamentally changed. Really from that moment forward, you're fundamentally changed. And there are so many changes that are happening at once. One is your perspective of things will completely shift. You know, what may have mattered before may not be as big a deal anymore. So something that, but also you still have life happening. You still have bills, you still have family, you still have, you know, children or needs or parents. And so it is an emotional roller coaster. And so sometimes, you really want to take your time to there can be a lot of grieving with it as well, and so everyone will deal with the diagnosis differently. I have some people who, you know what, they may want to just kind of pour everything into work. And like, what's important to me right now is that I continue to work because it keeps my mind off of it. Or for some people, it's important that I continue to work so that I can keep my health insurance, And so these are important discussions that you really want to relay to your oncology team, because sometimes I'm not thinking about what may be important to you at home. Um, I've had people who, like, you know what? I pick up my daughter from school on Wednesdays. I absolutely don't ever want to do anything on a Wednesday. I had another person who said, you know what? I have a birthday party and I want to feel good for my birthday party. I want to feel good for my cruise. I want to feel good. Whatever it is that's important to you, make sure that, you relay that, because we will jump through hoops to make it happen. We really will. But, back to the emotional part of the journey is that um, it really is up and down. And some days there may be more highs than lows. Some days there may be more lows than highs. And I think this is why something like Living Beyond Breast Cancer is so important, because I'm actually looking at the chat box and I see people
Yes.
connecting, just through the chats from this, and knowing that there are other people who are going through what you're going through, because I'll tell you, your family often doesn't understand. And often you may be the strong person in the family, and so, sometimes you're navigating the needs of others when you need someone to help you navigate what you're going through. And so I think that's sometimes where this community is so important. And what I wouldn't want you to do is to isolate yourself and to think that, you know what, I'm the only person who's going through this, because you're not. And there really isn't anything that you can't get through, but it's hard when you do it by yourself.
Yeah, it really is. And thank you for highlighting that and highlighting the resources and the people in the community that are available to everybody who's joining us today and anybody who will listen to this as a recording. That's such important information for everybody to keep in mind. And thank you for that.
Yeah. And I think, kind of while we're on
Yeah,
that subject, family, why don't we just kind of delve into
great.
family? Because this is a big deal, because there are children and spouses and other people who are a part of your circle. And I think one of the more important things that you can do is to sit down and talk to them about what you need and what it is you want. So sometimes I'll see where a spouse or a child will for may speak for you. and then you may not speak up for yourself because you don't want to hurt feelings or something like that. But I think this is really a time to make sure that everybody knows exactly what you want, and it's clear. It may be, who do you want to contact regarding what's going on? Who do what is it that you want? Sometimes we may have discussions and you communicate that to your family, like, this is what I told Dr. Lamar. This is how I feel about it, and that's that. So that they know.
Great. Yeah, thank
Okay?
you. That's really helpful. I'm glad you delved into the family topic because it's such a critically important one. So I noticed in the chat as we've been talking, and I'm sorry, I should just stop and mention we have just under 10 minutes already because the time has flown as it always does. Actually, before I say what I was about to about the chat, is there anything else from your slides, Dr. Lamar, that you do want to make sure we get back to that feels important?
I think we hit most of it. I think we're finished with the slides.
Okay, very good. So audience has been amazing in asking really insightful questions, and they continue to. And I noticed in the chat that there was some discussion, really great discussion and interaction about second opinions and how important that could be. And I wondered if you might also say a few words about that in case that'd be helpful for the audience.
Yeah, no, second opinions are great. I love when patients get second opinions because, one, sometimes the second time you hear something, you already have an idea and you can ask more questions, and sometimes people can present things differently. So absolutely get a second opinion, especially when we're thinking about, hey, is there another place that may have more clinical trials, or is there, and this is really a relationship, that you have with your oncologist. And so you really want to have a good relationship with your oncologist. And sometimes it just doesn't fit. And so you may just need somebody else. Sometimes it's a matter of, it can be any number of things, and it just may be a better fit somewhere else. So absolutely get a second opinion. I will tell you recently, and this may not be for everyone in the audience, I know some insurance companies have been limiting second opinions. And so that is unfortunate. And so in that particular scenario, again, that's why having these resources like Living Beyond Breast Cancer and other things are so important, so that like, hey, is what they're doing, is that standard? Is this crazy? Are we off the wall here? Or is this what other people would do? So that there are other ways to get the information that you have if you're experiencing the challenge of not being able to go to a second opinion. And sometimes it's a matter of travel.
Right.
Just having the resources to travel, or maybe it's just that I don't feel good right now, and we may need to start treatment quickly. But absolutely, if you can get a second opinion. I also think getting a second opinion earlier is the best, if you can. So you get the diagnosis, see your first oncologist, go ahead and start making plans to get a second opinion if you want to. So I'll offer it to my patients. Hey, you want me to get a second opinion? Make sure I'm not a quack. And some people will say yes, and some people will say no. And then I'll say, okay, well, the door is always open if if you're interested in the future. But it's often good, sometimes with the second opinion too, depending on where you go, is that you get a second opinion of the pathology.
Oh, interesting.
The pathology is the most important thing. So most of the oncologists, generally, we kind of know what we'll do, how we'll do it, generally. But we're relying on the pathology. And if there's anything wrong with the pathology, then that treatment plan can go off the rails. So I think one of the values of a second opinion is not just getting more information, getting another set of eyes on what you're doing. It's also getting a second opinion of that.
Oh yeah, that sounds so important. Thank you for bringing up that point. I too am learning a lot today as we all talk with you. So thank you for that. So we have just a few more minutes, and I'm just trying to prioritize because there are a few unanswered questions, but you have hit on many, which is great because there have been a lot of really good ones. I'm wondering, as we get closer to wrapping up our time together today, if you might share anything that you see kind of on the horizon, kind of what to look for in the way of new treatments or ways to manage side effects, kind of for people living with metastatic breast cancer.
Oh, good. So now you didn't ask this particularly, but something that's on the horizon that we're watching that we're not sure what to do with yet, and that's the concept of something called circulating tumor cells, where you do kind of take your blood and see if we can measure, the tumor cells in the blood. Right now, that's early. I wonder in the next couple of years, as we have more information, how we can use this to better define who may need what. So that's something that I'm interested in. I can't act on it right now because right now it just kind of only causes more stress. If we know it's there and it's like, well, I don't know what to do about it. But I am curious, like in the next 5 years, if we have this talk, how that will change where we are. So as far as managing symptoms, really, with symptoms, if your oncologist is not doing a good job of managing, I really think palliative care is what right now would be a good idea for you, because I have some patients that I've said, I'm like, look, I am not doing a good job of managing this. I think we need to step it up and do other things. But one of the things that I'm also pleased about is kind of more of the emotional piece of it, that we're recognizing how that impacts things. Because if you don't feel good, who cares what treatment you're on if you don't want to get out of the bed, or if you don't, feel like engaging. The reason why we're doing this, we want to prolong life, but we want to prolong good life. We want good quality life. And so what I think if you feel better, it sure does feel like you live longer.
Yeah.
So I like the dialogues that we're having. I like, I like where this is headed.
Great. Thank you so much for your perspectives on that. We have been so lucky to have your time today. So I'm going to bring us to a close in a moment. Is there anything else, Dr. Lamar? It's fine if there is not, but anything else you would like to add before we wrap up?
So this is my last closing words, and thank you so much for all of you who have been putting up with me for the last hour. I really appreciate your time. I hope that it's been, somewhat helpful to you. And I wish you the absolute best on your journey. And I always like to end with saying, you may have cancer, but remember, cancer does not have you.
Great. Thank you, Dr. Lamar. I love that. Thank you for ending with that.